Now, in full disclosure, these guys don't know what cases I have, so this is going to be interesting. Okay. Okay, so these are, so until 4 or 5 years ago, at least for the first 6, 7 years of my practice, I would record and keep files of every complication that I personally had. So this is from, so yesterday I was like, let me see, and I had close to 60 over 12 years. So then choosing 5 out of those was a challenge. So this could be as short or as painfully long as you want. So are we missing one individual?
I just called Dr. Kanwal. She has primary right now.
Okay, that's fine. I mean, she's with the patient. Okay. All right, so I do not have any disclosures. So case 1, I've just called it just another day in the cath lab. Okay. Can you guys see my slides? Okay. I don't know if I have a history for you. So this happened to be, I don't know, I had a flight at 4 p.m. and this was 2 p.m. and there was a snowstorm. And my interventional fellow said, well, I can't get the wire up through the radial. So I was like, just got in the room and I really pushed the wire hard, a J-tip wire. And then the wire went through, but the patient started complaining of pain in her right arm or in his right arm. So I was like, okay, this doesn't look good. So pull the wire out and this is what we have. Dr. Ayaz, what do you think is going on?
So this is very obvious complication we usually see in our cath lab. This is the radial artery dissection, perforation.
Oh, is it a dissection or is it a perforation?
Looks to be a perforation because there is extravasion of the dye.
Okay, so it is a perforation.
Yes, this is a perforation.
Okay, so I think I already told you why it happened, because I pushed the wire. So understand, complications happen because of operator error. That is the first thing you have to tell yourself, this happened because of me. Don't blame your fellow, don't blame 10 other people. You did this, own up to it. This happened because I pushed the wire. Okay, so what should we do now? Now we're in a mess. I'm going to miss my flight.
We don't have wire inside now. This the check injection through the sheath, most probably. So the first attempt should be to wire if it is easy.
No, what's the immediate thing you should do when you see this? What's the first thing you should do right away?
Right away, we should secure the wire, and then we should be going for the balloon tamponade.
No. What's the first thing you see this? What's your spinal reflex? What are you going to tell? What are you going to do when you see this?
So, then we can apply the crepe bandage.
Okay, you're going to. Okay, nobody's allowed to laugh, or I'll invite one of you Einsteins to come on the podium. Okay, so let's not do that. So you're going to hold pressure, right?
Yeah.
Because this is the arm, and you've got sheets in there. And those sheets are very rigid, and if blood accumulates, what's going to happen? You're going to get compartment syndrome.
Yeah.
The patient's going to lose the right hand, and it'll be a big disaster. So when you see this, the first thing should be just to hold pressure before you do anything else. Okay, so you can see I'm holding pressure with one hand and injecting, and when I inject, it's very important to demonstrate that when you hold pressure, you're occluding flow. It's very, very important to confirm that the pressure you're holding is actually tamponading the artery, because there's a lot of soft tissue in the arm. Okay, if it was someone thin, then you've got to confirm that. Okay, now what?
If you can get the excess, then if you pass the sheet and you can pass the coronary wire. If you are lucky enough to pass the coronary wire, then you are
okay
done.
So I tried passing a coronary wire, it's coming out of the artery.
Okay.
Then
That is difficult.
Then we can have the pressure cuff. We can apply the pressure cuff.
Okay, so good, very good. So you put a blood pressure cuff to above whatever the systolic pressure is. All right, and then what? Okay, so we did that and we left it up for a good 10-15 minutes. But still, there is extravasation.
But it is remarkably subsided.
No. We're holding pressure.
We can apply the crab bandage or a BP operator's cuff 10 to 15 millimeter.
We did that. This is after that.
Okay.
Still bleeding like crazy.
Have you given the heparin? We can reverse.
No. That's one reason I never give heparin in my cocktail. I only use 2.5 milligrams of rapamycin. See, this is more exciting. They don't know now. They're going to have to think. Otherwise, it was Mahesh. He would have told me something about a trial that I never heard about.
What we can do that after wetting of 10 to 15 minutes of so after wetting of the 10 to 15 minutes of cuff applying, then we can also try with the crab bandage.
Okay.
And even if before crab bandage, we should again try with the wire. And if our wire crosses, then we should go for the balloon tamponade. So that we should
so if the wire doesn't cross
this is very
antigrade,
this is very important that they should heal. If not with the balloon tamponade, then even with the catheter, if we are crossing the guide catheter through this perforation and it goes away from the perforation, then it will definitely tamponade with itself after completion of the procedure.
I'm telling you, I can't get a wire across. I can't get a 014.
If wire is not crossed, you can apply a crab bandage and check the sign for compartment syndrome.
Very good. Get another access and try to come from the other side. Even from the other side, the wire is out in the muscle.
We can call the vascular.
So you can only imagine how hard I must have pushed.
We can tamponade the proximal part.
Yes, you can, but please understand, if you do, the palmar arch is going to supply flow, right? Because you're going to only occlude unless you're suggesting we put a balloon in the brachial artery, would be a big no-no. You don't want to do that.
By taking above the level of the perforation side, we can put the wire above perforation after the bifurcation, and we will put the balloon on there and if the wire is not going.
Okay, so I'll tell you, we tried everything. None of that worked. You have a point? Exactly. Yeah, so that's what we did. I called my vascular surgeon. He came in, and he was like, "Aren't you on a flight right now?" And he was like, "No, I got this." So he just did a patch, and he said that the entire artery was a big hole. So just be very, very careful, because see, unlike the groin, where we are in the habit of following the wire go up, we don't do that for the rest, right? We are just used to looking at so if you have any resistance, just do not push. Just do not push, otherwise you're going to have. And the most important thing is, when problems happen, you got to own your complications, okay? If you don't have I'm looking for the right word. No, not courage. If you don't have the decency to do that, you should not be practicing interventional cardiology. Okay. All right. So that was case number 1. So this was this is almost a 9-year-old case now, or almost 10 years old. One of my earliest cases in practice. 65-year-old in China, big female, positive stress test, lateral ischemia, straightforward, long circ lesion. So they stented the first lesion, as you can see. Okay, and we're just trying to put another stent, just sizing with the balloon to see, okay, we'll put a 3/5/15 stent over there, okay? So, what?
Already told.
Perf होगा? यार आपको जादूगर होना चाहिए था. You're in the wrong business, you know.
Oh.
Yeah.
मुझे लगता है, I think he's hacked my computer, you know.
So now this is the grade 3 to 4 perforation.
Okay, what's a grade 4 perforation? Why don't you tell the audience what a grade 4 perforation?
Grade 4 perforation is the free flowing into the cavity.
Into a cavity?
Yeah.
Okay, it's intracavitary spill.
Yeah.
So I don't remember, somebody had sent me a perf where it was filling in the LB cavity. So that would be a grade 4 perf, and a grade 3 is a free-flowing perf in the pericardium. Okay, so it's a grade 3 perf. So what is wrong with this picture?
Wire is not.
I mean, the
distant.
wire has a loop. You'll advance the wire, right?
Yeah, we have to advance the wire.
What should we do at this point?
And if the balloon is there, balloon is mounted
Yes,
over the wire.
exactly. So now, whoever scrubs it with me, I tell them, before you pull the balloon out, always do a test. It's because of this case. I pulled the balloon out and not taken a picture. I was like, okay, we're done, which is why I've already pulled the wire back that we are done. Okay, so once you deploy the stent, you bring the balloon down, you've got to always do a test. So what should we do at this point?
At this point, if balloon is there, so we can go outrightly through the balloon tamponade there at the portion, and then we should be we should be preparing to take needle for the pericardiocentesis too, because this patient will have the compromised hemodynamics, and we should be prepared for the graft master, and then we should be doing the ballooning. If it seals, then it's okay. Otherwise, ultimately we have to involve the cardiac surgeon.
Okay. So what would you do?
Sir, I agree with Dr. Shabir. Hemodynamics are very important. We have to look the monitor, and we have to see the patient if he's complaining of chest pain or hemodynamics are down. Number second, we have to call for the echocardiography on hand.
What's the first thing you have to do?
So we have a balloon inside.
What size balloon
we are
would you
lucky
take?
that we have a
what size balloon
there.
would you take? I told you this is a 3, 5, 15 or a 18 stent. I don't remember. And somebody pointed out that there are two perfs. He's absolutely right. Who said that?
They are the distal perforations.
Huh? Okay, Electra aapka hua. Okay, so you take the same size. You go up to 10 atmospheres. You don't undersize, and then you do a test to make sure that you have complete occlusion of flow. That is very, very, very important. Just don't inflate a balloon and assume that you have occluded flow. So the important thing is to inflate a balloon to 10 atmospheres. Don't go super high, because probably went crazy and deployed it at 18 atmospheres.
It is not mandatory to inflate it again in master. Where the flow stops, then do the complication. If it is inside, the flow stops to the toilet in master, then it will start the bubble. If it is not supporting, then it will stop the bubble. I need to say we have to stop that.
Okay, so you bring up a good point, but you can understand that with every bead, this person is spilling about 10 mLs of blood in the pericardium. Okay, so if you are going to do a graded protocol like that, at 10 do a test, and then at 11 do a test, and then at 12 do a test, and then at 14 do a test, that'll be problematic. No, so I disagree with that. The idea is to occlude flow. So all you have to do is inflate the balloon, do a test, and make sure that you don't see any flow down that artery at the ostium of the balloon. Nothing past the balloon. Okay? All right, so should we give protamine?
No, sir.
No.
Why not?
Because we have just placed the stent.
Hardware is inside. Hardware is inside. We should not give. And one thing I want to mention, we can use the perfusion balloon if they are available. You might have seen them in US, in which
they're of historical significance. I don't think I've heard about a perfusion balloon, but who would go and look for a perfusion balloon?
If they are available.
Yes, I mean that's a good
balloon
point.
tamponade. Another thing is graft masker. Another stent is papyrus, which is single stent with PTFE mesh. It has the low crossing profile and easy to deliver.
Okay.
So we can use that papyrus stent as well.
Okay, all right, those are good points. Yes.
Sir, meanwhile, balloon tamponade, we should get another access also, and we should get ready for the graft master. As Haroon is
so you said you would get an echo and you would monitor the hemodynamics. Okay.
All right.
And then how long do you keep the balloon inflated for?
Sir, we should inflate the balloon sequentially for 2 to 5 minutes. Then we should have ready second axis, and we should have graft master ready on that wire also.
Okay, those are all good points. So you can see just with balloon inflation, we got this sealed, and you can see I have a graft master ready in the left main. Once we established that, I waited another 15-20 minutes. You check your ACT, obviously. There's a thin film of pericardial blood, but nothing too exciting. So what's the issue with taking a graft master down? Who has used a graft master in this room?
We all
have used.
Oh my God. I have never seen so many interventional cardiologists pick up their hands for anything, you know.
Graft master.
Sir, issue with the graft master is that one is the deliverability of the graft master, second is the re-stenosis rate, around 30% stenosis over the year. So that's why it's avoided.
Graft master is a double stent with the PTFE mesh, and they come in a size of 2.8 up to 4.5. And with 4.5, you have to take the 7 French guider. So that's another issue. And deliverability it is a bulky stent, so it is difficult to deliver.
Thank you.
And high rate of ISR and stent thrombosis.
It can also cross with the 6 French guide, graft master.
Up
but
to
the
4.
problem is once our balloon is inside, we cannot take graft master inside. That's why we use another papyrus, which is not available in ICVD, and you might have used in, I think, USA.
Second, we have lifelong FD
Why doesn't it endothelialize? You said it's what? What's the structure of papyrus, of graft master?
There are 2 stents, and between these 2 stents there is a PTFE, and it can even occlude the side branches as well. So it is the bulky stent, and it is difficult to deliver, and high rate of ISR and stent thrombosis, and lifelong anticoagulation.
No, the biggest issue I've had with the graft master is, especially in tortuous arteries, especially in SARC, no, it comes, the stent comes off the balloon. The stent, it has happened to me 3 or 4 times. The stent comes off the balloon. Okay, so you have to be very, very, very careful with the graft master. So the past few years, when we had that, the simplest technique was to take a second guide, take a guide liner down. The guide liner also seals your not completely, but seals your perforation, and then you unsheath. But now we had papyrus available. That is also an issue with papyrus, but it's less bulky. Okay, all right. So this is a very strange case. Okay, this is like at 4 or 4:30 p.m. Or
this graft master doesn't endothelialize. What about PJ papyrus? That also doesn't.
no, so people say it does, and the other thing people say about graft master, I've never done it myself, is to put a bare metal stent on the inside. You see what I'm saying? Take a graft master, say you took a 4-5, you post-dilated with a 5 or short balloon, okay? And then put a bare metal on the inside so that can form endothelium. Now that is all anecdotal. I'm not aware of any data that proves otherwise.
That is going to give 4 layers of stents, because one was placed before, and then 2 layers of graft master and the.
No, but you know, when you say 4-5 graft master, we're talking about the lumen. The lumen that you're going to get would be a 4.5 millimeter diameter. So it doesn't matter if you have 6 layers in the wall or not. Okay. Yeah, but that's a good question. I don't know the answer to that. Okay, so this was a very strange case. So our thoracic surgeon calls us to the cath lab, which is probably the first time I'd heard of him. And he says, listen, this patient had a left upper lobe tumor. I was resecting that, and I think I may have nicked the patient's lima. So I was like, okay, does the patient have a history of cabbage? He's like, yes, that's exactly why I'm calling you. Okay. So right from the OR, so I was like, is the patient having SCL? He was like, no, he's under general anesthesia. So we brought him to the cath lab, And we took a picture of the lemma, and the lemma was occluded in the middle. And then we took a picture of the right, and from the right you could see very faint collaterals going to the LAD. So in this case, we did what is a classic ping pong technique, okay? So the way you really do that is you would take a second guide. We could have also used the left radial, okay? And you already have a balloon. You deflate the balloon, get the wire down, and then reinflate the balloon. You get your graft master stent down, okay? And then it's very, very important to make sure you pull the second wire, because you don't want to jail the second wire behind the graft master. You're going to cause a spider dissection of the lemma or whatever artery. So this case kind of nicely demonstrates that. So you inflated the balloon, pulled this wire back, and deployed the stent, and the patient did just fine. Okay, so understand. So the first thing is when you see a cornea perforation, now I will tell you a lot of times people panic, and that's the last thing you should do. Get an echo, and if the patient gets hypotensive, don't say, oh, the patient got too much sedation, or maybe he's getting PVCs, because your mind is going to give you a lot of alternate diagnoses, especially when your epinephrine level is that high. So try not to think of alternate diagnoses. Don't ignore the elephant in the room. The patient's hypotensive because he's spilling in the pericardium. So have the balloon inflated, and immediately what you have to do is to get access in the pericardium. If you don't feel comfortable, ask your colleague, okay? Because see, at the end of the day, this patient has an extremely high risk of death, okay? So if you can involve 2-3 team members to come and give you a hand to save the patient, please don't do that. Just don't bring your ego inside the room, okay? There's no reason why someone should die from a cornea perforation. Although this year I had one young guy die. I don't have his images with me, but that was probably the most dramatic case of my career.
Can I add something?
Okay, somebody has a very soft voice. Oh, Gigi, sorry.
There was a case in Jack last week in which there was left main perforation.
From a rotablator.
Yeah. So what they did when they were crossing the wire, it went into pericardial space.
Yeah.
They did nothing. They put another balloon and sealed that entry point into pericardial space, and they inflated the balloon. So they sealed from left main to pericardial space. So now they put another wire and it went through the left main, and then they put out that balloon which was crossing the pericardium, and then they stented it. So it was.
Yeah, I think you should all see that case.
Not very far. It's like 8 months back. We had a left perforation as well. And what we did, we initially did the balloon tamponade followed by the replacement of the stent.
But in the case they tamponade the left main to pericardium. Wire went into pericardium. They were not doing the tamponade of left main, but that hole in the pericardium.
Okay, so because I've had so many perforations, we put a proposal to NCDR, and we published this in circulation a while back. So these are 30,000 cornea perforations. This is the most extensive report on cornea perforations to date. And so what are the predictors? Female, sex, black, race, a high-grade lesion, a complex lesion, a longer lesion, obviously CTOs, that's no-brainer, vein graft. If you'd use any kind of atherectomy, either laser or rotational atherectomy, okay? And what were the predictors of mortality in this cohort? If we used a covered stent, because those were really the most disastrous perforations where you had to use a covered stent. Patients who went into shock, patients who had a cardiac arrest, and obviously the more complex the lesion, those independently predicted mortality. So again, we've already discussed this, but just a quick overview. what you really have to do is take a balloon that is 1-to-1 sized. Okay, don't take a larger balloon and leave it up for about 10 minutes. You should be very, very facile with doing pericardiocentesis. Sometimes you could bleed behind the left atrium, okay, and the patient could get an isolated left atrial compression with no, so in those cases you probably have to go, through the interspaces. So so you should really act on that as soon as possible. And sometimes you can't control the bleeding, so in that cases you don't worry about stent thrombosis. The patient has a circ. Now just say it's extreme situation, okay, you can't get I had a case, but obviously I just chose 5. We were trying to open up a circ CTO, and we caused the worst possible perforation you could think of. And it was a CTO, and there's really no way off. And the issue here was that we were all in the subintimal space, and then we ballooned trying to do a cart. And well, we ballooned and we caused a nasty perforation. So when we ran out of options, then what we did was we put a stent from the left main into the LAD, a covered stent. So we totally excluded that circ. So when you have cases like that, you could really totally shut off the side branch, especially if you're working in a diagonal. Patient will have pain, but the likelihood of patient dying from a diag or from a PDA or from an OM or a non-dominant circ even is relatively low. Okay, and obviously if it's a wire perf or a nasty perf, you could just coil the main artery. You could just put a coil in the prox circ, in this case, for instance, and just let the circ impart. Okay, so again, we've already talked about this. This is really for your handbook, so you can look at it. All right, so I think Haroon will probably take this. Just another STEMI, okay? So this is a 80-something-year-old female. Distal right was occluded, ballooned, wasn't good guide support, so I took a AL guide, okay? Then put a stent in, okay? All right, stent is deployed nicely. No issues here. Do you guys see any issues here? What? There's nothing wrong with this picture.
अभी
okay?
तो कुछ नहीं है भाई, ये prediction कर रहे हैं.
Okay, so what's going on here?
It's a cuspal dissection which is extending into even ascending aorta. So what we do, since wire is in the place, we have to seal the ostium first.
Okay, but Mahesh wants you to take a caudal view, areocaudal, and some other views.
I think it will not be wise to give too much dye. It will cause a hydrotrauma.
Okay.
It will further
So what should
extend
we immediately do?
Stent the ostium, seal the ostium,
Okay.
and after stenting it, we will see if there is any further dissection.
Okay, now you see how farther back the stent is. Who was discussing 4 or 5 millimeters and the risk of stent thrombosis? Who was that guy?
Gulzar.
that Gulzar is not
Dr.
here?
Gulzar.
Okay, so you see, in this case, you have to be 100% sure. So how many millimeters of stent do I have out in the aorta? 5 or 6. I don't give a crap about that. I've caused a type A dissection. And unless I seal the entry point, this patient will have to go for emergent surgery. This is an elderly female who came in with a straightforward inferior wall MI, and now I've caused an aortic dissection. So, don't act too cute and say, oh, it's 2 millimeter, 3 millimeter. Just deploy the damn thing, okay? Seal the dissection. If the patient has instant restenosis, who cares, okay?
So putting the stent, we have to go for CT scan. It will show the extent of dissection.
Yes,
If
yes.
cuspal dissection is more than 40 mm, then the surgeon has to be involved. If it is less than 40 mm, we can observe and we can even manage conservatively.
Most of the cuspal dissection,
most of the cusp dissections are self-limited.
Do you think this is a cusp dissection?
No, this is involving the ascending aorta, and we don't know if there is impingement of the great vessels or not. We don't know.
So what should we do?
First, we have to seal that with the stent.
So we've already done it. At this point, what should I do? Do I just call it a day, or is there anything else I can do?
So this is a type 1 cuspal dissection. You can leave this patient there, and we should repeat with the CT scan or TE.
CT scan. There is dissection.
Okay, so what do you guys see?
Yes. Yes.
Now the dissection is above the cusp.
Okay, what everybody has to learn in this room is let your optic nerve communicate with your occipital cortex. Okay, let it process that in your gray matter before your lingual nerve gets stimulated. Okay? So activate your optic nerve, let it get processed, and then don't stimulate your wherever that frickin' nucleus comes from. Okay? So what do we see here? Is this a free-flowing dissection? Is this contained or is this not contained?
Yeah. There is a filling defect that is into the aorta and most likely suggestive of dissection that is extending from the ascending towards the descending, I guess. And flow is maintained, and that is more towards the right coronary cusp. That starts from the right coronary cusp. So
what should we do?
We should further delineate this with the CT.
Yeah.
And we should be avoiding further injections.
No. I think what this confirms is if you pay attention here, this is nothing but an intramural hematoma now. There's no flap, it's not expanding. So what I haven't shown you is we left this patient on a table like this for 15 minutes, and the dye that was trapped in the aorta stayed over there. Okay, and that reassures you. So you don't really have to take the patient from the cath lab to the CT scanner. Blood pressure is fine. You want to make sure blood pressure is not 280, which is usually the case in the very elderly. Okay, got a CT scan, there's a big hematoma, got another CT scan in the morning, and it had resolved. So I gave this to one of my fellows who said he would write it up. To this day, it's been, 12 years or something. He's not written up. Okay? Alright, so...
At this point, one would think of doing an aortogram, but you have done an LV gram.
Yeah.
So is there any benefit of doing an LV gram?
Okay, why would I not do an aortogram?
Because
We have to look for the aortic regurgitation in this patient with the cuspal dissection.
No.
No.
So in my opinion, aortogram is contraindicated in cases like this.
Yes.
Because you do not want to inject anything above 10 to 12, PSIs in the aorta.
It will cause the hydrotrauma.
Right? So because I don't know, I'm just going by what I saw on the angiogram. And what was concerning was that initial dye had cleared, which, so if I take you back, no, not really. Because the heart is contracting anyways, I'm not doing anything to the heart. The heart is pumping out blood, right? How much does it add to the LV pressure? I don't think it adds anything significant. Okay, all right, so this is a good case. So until 2017 or 18, it was our practice that anyone who was referred for TAVR, I would routinely do an angiogram on them. And then, and then we probably did a lot of inappropriate PCIs in these 90-year-old patients and whatnot. The fellows loved it because almost everyone needed a rotablation, everyone needed a PAV and whatnot. So this is just an 84-year-old came in for a routine coronary angio, okay? So I was in the control room, and you can already see from the aortic valve how calcified and restricted this is, okay? So, as expected, a patient really didn't have any coronary artery disease, with the exception that, and there was like a non-dominant or a codominant right, okay? So she does the angiogram, and I just saw the first two pictures. I moved on to the next lab. And then she called me and said that, the patient is vomiting. In a patient with critical AS, vomiting is a very, very, very bad sign. So she's done, she's about to pull the sheath out. She's like, oh, the patient is. And I go in the room and the patient just does not look good. So she's like, no, I just took pictures, I reviewed the images, and everything looked just perfectly okay. I asked about sedation, given her usual thing, and asked him if he was having trouble breathing. He just was not responsive, so I thought maybe he's had a stroke. But then I was like, let me go take another look. So I went back with the catheter, okay, and now you can see the patient has started to really slow down, okay. So what has happened now? Left main dissection. Okay, who says left main dissection? Okay, let me show you the images that were done about 3 minutes before this. There were only 3 pictures. 2 pictures of the left and 1 of the right. And you can see the LAD filling all the way down. So how could this have embolized? So you see this, right? So now, the left main does look funny on this chart, right? It does look funny, but it wasn't significant. So went back with a guide catheter. Now the issue was that the arch so tortuous, I wasn't sure where the wire was going. So I had to use a micro catheter to get the wire down. Okay, and now the patient has really, really become hypotensive. Patient's become hypotensive. We started pressors. He's getting bradycardic. And this patient had just come for an elective outpatient. So I ballooned from here all the way back, and I wasn't sure. I was like, maybe I'm in a subintimal plane because the artery was so tortuous. Just couldn't get any flow, which was very, very odd, because if there's a clot, you would balloon. I couldn't get a 2O balloon down because of extreme tortuosity. So then I thought that, okay, this has to be an embolic event. Took a guide liner, aspirated through the guide liner. There's a big chunk of calcium. There's a big chunk of calcium that broke off the heavily calcified aortic valve. You know, so when she was pulling her catheter out, the wire rubs against the. I mean, this is again my hypothesis. Because I just could not get a balloon down. It had to be something extremely hard. Otherwise, if I showed you this LAD, you would be like, this is a no-brainer. A first-year resident could wire this LAD, right? So then again, with the guide liner, we aspirated, sequentially ballooned it. But the patient actually never recovered. Despite getting, you can see, nice to meet, and you can already tell that his LV was completely normal. And he had very critical AS, but we just could not get him off pressors. Got intubated. So then we decided to do ad hoc. So this is the final picture. Okay, looks pretty good, right? So we crossed the aortic valve. Just could not get a 22 balloon. So I had to take a peripheral balloon, a 8 or a 10 now, to create space to get a bigger balloon down. Right? But you can see how extensively calcified that valve is. So at this point, what should we do?
You did the ballooning of the aortic valve as a palliative to enhance some flow to the aorta to improve the cardiogenic shock, because there was a critical aortic stenosis already, and she was on pressors too, but she was not responding. LAD occluded for some brief duration of time, then there was
not brief. I would tell you, between the time it occluded, like I said, I just could not get flow down the LAD. I'd ballooned from the apex. I thought I dissected the artery, and then as a last thing, I said I would get a guide liner down and see what we see. And thankfully we did. So there probably was a good 25-30 minutes of zero flow. So obviously the patient EF went down, and then on top of critical AS, she went into flash pulmonary edema, had to be intubated. So we had to do a bailout BAV. So the point of these cases seemingly straightforward. Every single case that I showed you, there were straightforward cases. There was nothing technically challenging about, and I deliberately did that just to impress upon you that there is nothing like an easy case. You could be doing a straightforward diagnostic cath and all hell can break loose. This patient could have died. Thankfully, the patient survived. We discharged the patient, brought him back 2 weeks later, did his TAVR, his EF. Never completely recovered, but it was in the 45% range. But he became very functional, went back golfing and everything.
We can think of mechanical supported devices.
Yeah, so that's actually a good question. Now, we had tried that initially in our experience. We would do BAV and put Impella in, but most of the complication was from exercise. And because this patient instantly responded to BAV. It's very rare. Obviously, didn't have any measurements, or patient had a CT but had not reviewed it. So this was just. So if you don't understand anything, it's always safe to take a 20 millimeter balloon. An adult will never have an aorta that is less than. If you're really concerned, take an 18 millimeter. You can never go wrong with an 18 millimeter balloon. Okay. So again, you will have complications. The more you do, you will have complications. And I will tell you every complication that you have, except I know of one, which was a very unfortunate incident that happened to this gentleman. Do you want to describe your case? What happened? No, not you. I mean, yours was your fault. I'm talking about him. Okay. The balloon that got stuck, man. Yeah. Here, take this. I'm done. And I think if we have discussions like this, we all learn from each other. Thank you so much for being such a great audience.